Good afternoon, everyone. We'll give people another minute to join. Number of people are now joining, and then we will kick off. Great. I think we can start. Once again, good afternoon, everyone, and thanks for joining us for this webinar, which is jointly hosted by UNAIDS, the Gates Foundation, as well as the Health Systems Trust. We've got an excellent panel lined up to talk about a report released in April by UNAIDS entitled A Triple Dividend, the Health, Social and Economic Gains from Financing the HIV Response in Africa. Today's webinar will focus largely on South Africa, but I'm sure my colleagues may hint at some of the impacts that a fully financed HIV response between now and 2030 will have for the rest of the continent as well. So with that as an introduction and welcome, I would like to introduce Ms. Eva Kiwango. Eva is the UNAIDS country representative and director for South Africa. She holds an MSc in policy and planning and has served UNAIDS since 2004 through postings in South Africa, Switzerland, and Mozambique. Eva brings more than 24 years of experience in international and local development, including policy and planning, evaluation, particularly around HIV and AIDS, working at country, regional, and global levels. Eva, can I welcome you to make your introductory remarks?
Thank you, Jürgen. Good afternoon and welcome everyone to this timely and important discussion today. UNAIDS is delighted to co-host this webinar with the Gates Foundation and the Health Systems Trust. And I'd like to make a special thanks to the HST corporate communications team led by Antoinette for organizing most of this. The UNAIDS Triple Dividend report was launched at an event co-hosted by UNAIDS and PEPFAR at the Kaiser Family Foundation last month in Washington, D.C., during the spring meetings of the World Bank and the IMF. The event included remarks by the Executive Director of UNAIDS, Winnie Byanyima, Ambassador Dr. John Nkengasong, the U.S. Global AIDS Coordinator and Special Representative for Global Health Diplomacy, the Finance Minister of Zimbabwe, and the Executive Director of the Kenya Legal and Ethical Issues Network on HIV and AIDS. David Humphreys, the Global Head of Health Policy for Economist Impact, presented the report findings. As we all know, ending AIDS as a public health threat requires political, programmatic, and financial leadership. All government sectors, including ministries of finance, play a key role in increasing and sustaining domestic financing to ensure that vulnerable and key populations are reached equitably and receive the prevention, care, and treatment services they need. I look forward to our engagement in unpacking the UNAIDS Triple Dividend report today and its implications for fully financing South Africa's newly launched National Strategic Plan for HIV, TB, and STIs, to accelerate our achievements towards the 2025 targets and the 2030 goal of ending AIDS as a public health threat. This webinar will touch on important questions relating to the dividends. But why are we raising this now? We know this is not new and the work has been done. Work has been done on this before. We are raising this now because countries are experiencing financial crises and are having to make very difficult investment choices, especially in health, education, and social protection. It's the right moment to remind governments and international institutions like the World Bank and the IMF that we cannot park a disease like HIV, because the spillover effects of investing in HIV into other health and non-health areas are huge, and they help economic recovery. Going forward, UNAIDS is looking at expanding this analysis that was done for the triple dividend report. So any suggestions for joint or individual additional analysis are most welcome. Before I end, I'd like to thank our esteemed panel who have agreed to clarify the report findings and what it means for South Africa, and especially our colleague Jaime Ateanza, who leads our equitable financing work at UNAIDS, and the development of this report. I would also like to thank our UNAIDS Regional Director, Anne Gifuku Shongwe, who is with us, and for agreeing to join this in-country discussion. I know you're very busy, Anne. Back over to you, Jürgen. Thank you.
Great. Eva, thank you very much for those introductory comments. Just to give a flavor of Africa, and I'll just mention a few things because the next set of speakers will delve into it in some great detail. You know, in South Africa, young girls 15 to 19 are 4 times more likely to be infected with HIV compared to the general population. 4 times. And that's, you know, we keep saying children are the future of our country, but they are at significant risk still of acquiring HIV. Yet we know that a fully funded HIV response can avert an estimated 1.35 million new infections between 2022 and 2030. Now that's 1.35 million new infections, but for that we need the HIV response to be fully funded. In addition, a fully funded HIV response will give us significant gains in our GDP. At the moment, our gross domestic product is very, very low, one of the lowest in the world. But a fully funded an HIV response can give us a gain of about 2.3% in GDP gains by 2030, which means that $1 spent on the HIV response over the next few years could give us about a $7 gain in GDP. So the return on investment is fairly significant. And I'll leave our next set of panelists to tell us a little bit more about the gains we will make by fully funding HIV in terms of health gains, social gains, as well as economic gains. I would like now to hand over to my colleague, Liesl Page-Ship from the Gates Foundation, who will both introduce herself and introduce our next set of panelists. Over to you, Liesl.
Great. Thank you, Jürgen and Eva. And good afternoon, good morning to colleagues on the line. Thank you so much for joining. It's my great pleasure to introduce our agenda and esteemed speakers. Dr. Thembisile Kulu will be giving some opening remarks, and then we'll go into 3 presentations. So without further ado, Dr. Kulu, if you could come online, please. Dr. Kulu is the CEO of the South African National AIDS Council and the chairperson of the SA Global Fund, CCM. She holds a medical degree and master's degree in public health. And prior to joining SANAC, she held directorship positions at Right to Care. Dr. Kulu is an esteemed leader in health with a wealth of technical expertise and leadership experience. Over to you, Thembi.
Thank you. Thank you so much, Liesl. I was actually starting to look around, wondering who you are speaking about. So good afternoon, colleagues and friends. Jürgen, can I just check, do you want me to put my camera on?
Yes, please, Thembi.
All right. So good afternoon, colleagues and friends. As mentioned, my name is Thembi Kulu. I am the Chief Executive Officer of the South African National AIDS Council. So today we are here to discuss the UNAIDS triple dividend report and its implications for South Africa. And let me once again thank the organizers, the Bill and Melinda Gates Foundation, UNAIDS, as well as the Health Systems Trust, for convening this timely and important discussion for South Africa. The report, as we've heard, was launched just over a month ago in Washington, D.C. It profiles 13 African countries, with 9 of them being in Eastern and Southern Africa. And South Africa is actually the first country to convene experts, implementers, to actually discuss the details, the implications, the next steps in terms of achieving the important dividends and spillovers from increased and sustained investments into the HIV response. South Africa does need to lead the way and set an important example for the region, because based on our burden, we know that if South Africa makes significant progress and we win in our AIDS response, the region wins, and indeed the world wins. We recently launched the National Strategic Plan, as was highlighted, which is based on really bold objectives, which also takes into account our learning from previous objectives. We plan to reduce barriers that prevent access to health and social services, and promote a new and urgent focus on inequalities for people living with HIV, TB, and STIs who are not benefiting from the treatment and care services that they should get access to. The NSP also makes important interlinkages between mental health services, social support, sexual and gender-based violence, human rights violations, as well as viral hepatitis as a neglected disease. As part of the NSP development, we also undertook a costing exercise to determine how much money would be needed to implement the NSP fully. We looked not only at funding from government, but also funding from our 2 major donors, being PEPFAR and Global Fund. Actually, Goal 4 of the NSP emphasizes the importance of fully resourcing and sustaining an efficient NSP, which is led by institutions that are revitalized, inclusive, and accountable. We therefore envisage that sufficient local and external funds need to be mobilized and allocated to facilitate the implementation and coordination of HIV, TB, and STI programs, and also to address the underlying risk factors. The total cost then of implementing the NSP is estimated at about 268 billion rands over the 5 years. And we also estimated that about 249 billion rand already sits within the fiscus. This leaves a funding gap over the 5 years of about 20 billion rand. The financial gaps are driven by the bold goals laid within the NSP, including the annual growth of people initiated and retained on antiretroviral therapy, which needs to grow by over 1 million people over 5 years. We also need to be rapidly scaling up, finding, diagnosing, and treating people with TB. Therefore, for the ambitious goals that are set out in the NSP to be achieved, we need to make sure that strategies to realize efficiency savings and mobilize additional resources, especially for priority areas where we have funding gaps, are critical. These include the key and priority populations, as well as the adolescent girls and young women, which Dr. Pillay referred to. So in this context, South Africa welcomes the additional analyses, such as the triple dividend report, and I do want to thank our colleagues who will be presenting. We welcome them because they are going to help us to be able to argue for more funding, especially analyses like these, which show that we are not just going to be saving lives, preventing new infections, strengthening health systems, which is very important, but that we are going to see improved outcomes in terms of education, social development, and substantial economic gains. We need these recommendations to come up so that we can help our policymakers to make very difficult decisions on allocating sufficient budgets for HIV, despite the unprecedented fiscal constraints. We are planning to include the results of this study into the resource mobilization strategy for the NSP. We also have on this platform today our colleagues from civil society. So let's engage freely. Let's walk this road together to mobilize resources to implement the NSP fully, to make sure that we meet the goals of the NSP, but that we also realize the associated health, social, and many other gains from the implementation of investments within the HIV for the benefits of our people. Thank you so much, Chair.
Many thanks, Tembi, for setting out that call to action. Lots of challenges, but also a lot of opportunity. Next up, we'll hand over to Mr. Jaime Atienzo to present the report for us. Jaime is the UNAIDS Director of Equitable Financing Practice in UNAIDS. He's a PhD candidate and has authored several books and articles. Prior to joining the UN, Jaime worked for several public institutions, private foundations, as a consultant and with global CSO networks. He is a recognized international expert in financing for universal healthcare and education, particularly on taxation, debt, and development financing. Over to you, Jaime.
Thank you very much. It's a real pleasure to be with you this afternoon. Let me start by thanking the Bill and Melinda Gates Foundation, our UNAIDS team in South Africa, and the Health Systems Trust for convening us all. And I have to say, I'm really honored to be here presenting this report that has been authored by Economist Impact and commissioned by UNAIDS. And I'm also really honored to be doing this, speaking after Dr. Shulu, that brings forward all the energy of one of the, well, probably the global leader in a national response to AIDS that normally anticipates the challenges and can anticipate some of the gains and the opportunities that can be used by others. And also from my colleagues, Gesine and Mark, that are going to intervene afterwards, because they are real thought leaders in this space, and some of their previous work has been inspirational for this effort that UNAIDS has undertaken. So thank you all, and as I say, it's a real pleasure to be here with you. Let me just, before I jump into the presentation and go to some of the data that I want to share with you about the South African specific case and some balance with the 13 countries that were included in this research work. Go back to our starting point, and our director, Eva, did that very well. We are really concerned that the AIDS response is in danger. I can say in danger because that was the title of our report launched last year during the Montreal meetings. So we see that progress has slowed down, and while we see the history of AIDS, and especially as we look at other pandemics, as a history of success, with so many people that are still dying year by year, and with the new infections reducing at a lower pace than they should and that we would expect, we cannot be at all satisfied, and we have to insist on something that has been mentioned by Yogan already. We have reasons for concern, for serious concern, and our past progress does not guarantee our future success. We need to continue. We need to make sure that the gaps are filled and that many improvements are made also policy-wise. So we are seeing also that financing is lagging. We are seeing that donor financing has gone down, and we are seeing that for the first time in the last two exercises, 20 and 21, that we have consolidated numbers for, there was a decline in domestic financing that really holds the bulk of the response across most of the countries, and specifically in the Africa region, in South Africa, as you all very well know. So this is the context in which we are operating. And as a second point, we are operating under what we can say it's the tail end of the COVID economic shock, with the economic recovery being slower than expected initially, with the impacts, the side impacts of the Ukraine war also hitting countries, especially developing countries, and creating very bad conditions for a sustained recovery still. So growth is slow, so is tax collection, and interest rates, because of inflation and because of the policies that have been put in place to combat inflation, have spiked, and we are seeing also that exchange rates are not going in favor, especially of African countries. On average, African countries have lost, are paying 10% more in their debt repayments just because of these international conditions in the last year. So a context that was already difficult has only worsened, and it will take some time before it improves. So That is why the sustainability of the AIDS response becomes such a critical priority at this time, because it's affected by all those international trends, also by the fact that we have been successful in the near past, and we have been seen as front runners in many areas. So the attention has shifted to other particular areas. So let's keep that in mind. We are seeing also that health spending has gone down despite what we saw initially in 2020 and partially in 2021. So as debt repayments went up, we've seen that health spending has gone down in a large number of economies, specifically in African economies. So we are at a critical point on the sustainability of the AIDS response as we move towards 2030, but we are still seeing that we are not reaching the targets of 2025. And with these financing gaps, we are putting that achievements at risk. So let's keep the tension and let's understand that we need to have the right financing approaches, the right, of course, medical, technical, epidemiological approaches and programmatic. And we also need to have the right political and communications approaches. And I think this work attempts to dive on the technical and on the economic and on the social, but also on the political angle. What is going to ensure that we can bring back the attention needed? And we will look at some of the numbers, and at the end we will look at some of the paths ahead of us, because we definitely are going to need additional resources. And we like to speak about three buckets: the domestic, the international, and the third bucket, where we can see resources coming from financial institutions, development finance institutions under blended instruments, and also other additional sources as can be debt relief instruments or allocations of or reallocations of SDRs that can potentially be utilized for these means. And at the same time, we need additional resources, but we need the better, and I would say the best use and the most and the highest efficiency gains of current resources. So we have to combine all those when we look at the results. And let me make a third point in this initial, before we dive into the numbers, that I guess it's what everyone is willing to do. But I want to underline that the AIDS response is at a crossroads. On the one side, because of the unfinished business and the need to grow the political priority, which I think is happening, honestly, after the time of the COVID response, when we are again managing to bring attention to the situation of AIDS integrated in the broader health challenges, but to bring attention to the introduction to the situation of AIDS. So that's part of the crossroads. We're also seeing the challenges of potential growing costs. And I would like to highlight an existing work by Gesine that she will not be able to share today because there's not enough time. But when we look at the long actings, next generation that are coming up into the system, if we are successful in that introduction, this could increase the gains, and Gesine will correct me, probably up to 20% if we manage to get all the people that would be needed to get into treatment, into this, into prevention, only in South Africa. So there may be additional costs that we have not estimated yet. So we need to be aware of this. And we don't have enough prevention and community response and community investment yet. So those are things that place us at a crossroad. On the other side, we are seeing the move towards integration of the AIDS response into broader health systems, integration into other instruments, and we are seeing how this trend is only advancing, and it's a direction that is a necessary direction that can bring a great number of efficiencies and of improvements, but that also comes with some risks. And walking the path is definitely much more complicated than stating the need for the integration and doing it rightly. So I think that also brings the crossroad. We have all these challenges. And finally, we know, but we have to demonstrate better, that the AIDS response is the backbone for a stronger pandemics preparedness and response, for stronger health systems as a whole, and for bigger and for broader and more extensive health security. So that's where we land into this research piece. And let me say first that I want to recognize the excellent work on the spillover effects that has been done in the past and on other related studies from our colleagues in PEPFAR and Professor Nanda Kumar, from colleagues in UNAIDS, and working with other colleagues such as my colleague Eric Lamontagne from Gesine and Marcus, with very interesting and sophisticated models. In the past, we have tried to take an innovative approach, and we were thinking we need a new partnership to bring to the table. So that's why we looked for The Economist Impact, the think tank branch of The Economist. And I'm going to move a little bit ahead to the next slide, because what we were seeing as I was speaking was a little bit of a teaser of how we've progressed, but how progress has slowed down in terms of new infections, in terms of reduction of deaths, and in terms of the numbers that bring us to today. And when we look at the report, and we are in the right slide now, what we are doing is comparing two different scenarios: 100% funding of the 2021 political declaration that looks until 2025 against a business as usual scenario where funding levels post 2021 enable service coverage levels to be maintained but not expanded. So we are doing this, and there is a novel quantitative methodology carried forward across 13 countries, but there's also a very deep qualitative work. There has been a large number of interviews with experts throughout the world and with some public officials and civil society voices in this front. Let's say that all the findings extend estimates from Avenir Health in the direct health-related outcomes of fully financing the AIDS response. So we are clearly building on existing work and trying to take a new spin in a certain area. And let me explain that very briefly. Next slide, please. So this is the model framework that The Economist Impact designed. So the idea, it's really this human capital pathway that adds, let's say, new value to this proposition, and that allows us to understand that there are these new dividends, and we always like to speak as economists of double dividends, and we thought that the triple dividend was a nice name so that we can really explain very clearly that there are several gains. Not only we have the moral obligation for the people, that is the number one and the main source of, I think, political energy and human energy to expand the AIDS response, but we also have these other social impacts that are really critical, and economic impacts beyond that. So as you see, we go from the investment that create reduced new HIV infections, reduced AIDS-related deaths, and you have some numbers for the 13 countries, and with the model, with all the assumptions that it has, and that of course need to go to cut across 13 countries and will fit differently each of the countries, but we see that 480,000 new infections would be averted. We look at the social impacts, from demographic changes to reduced inequalities and improve education outcomes. And we see here 3.4 million fewer orphans, an increase in the population of 2.5 million, and 430,000 additional children in schools. So these are social impacts across just the 13 countries and towards 2030. And we end up with the labor force growth, labor productivity growth, and GDP growth, with 1.6 million people added to the labor force and up to 22 billion in GDP gains. And of course, South Africa being the largest economy of the sample, it takes and because of the particularities of the epidemic and the size, of course, of the epidemic also, it takes most of these results. Let me move now to some of the specific results. Next slide, please. So this is an aspect that in UNAIDS we are paying special attention, and I have to say, especially in East and Southern Africa, specifically in South Africa, and that's why I wanted to show the slide with results from different countries. We see that the impact of the full investment is especially intensive in protecting young girls. We see here that while young girls, that group of population is around 5% of the population, they would go up to 15% of the new infections of HIV averted. This is in itself one aspect, and of course I can't get into other items, but I can't refrain to mention that improved secondary education and improved participation and presence in secondary education, such as we are proposing with Education Plus, would also make a huge difference for adolescent girls in this particular aspect. Let me move to the next one. That is really a different way of projecting how adolescent girls and young women have see a special impact. Also, if you look down at the graph in the groups of population between 15 and 24, you see that there is really growing impact and growth in population of women, of females, of female population. Let's say prioritizing this particular group where we see that there is a very high concentration of the epidemic in the region and in South Africa particularly. Let me move to the next one. Here we have the difference in school enrollment under 100% funding scenario compared to the business as usual. You see that the differences are in the hundreds of thousands, particularly in South Africa, and you can see that the impact is really high, 131,000 additional children, boys and girls in school. So this is another impact, and let us move to the next one. Here we see the difference in total GDP from one financing scenario to the other. And again, we see that at least 4 countries, Kenya, Botswana, Mozambique, and South Africa, have a change above or an increase above 1%, which is really relevant, very significant in the case of South Africa, up to 2.7%. Of course, it comes without saying that when we look at some of the specificities of South Africa, and if we want to discuss and narrow down the conversation on some of those, we would have to dive deeper into some of the dimensions, specifically some of the labor dimensions or the capital accumulation dimensions that have been specifically left aside to in this modeling exercise. But we can see that there is, I think, across the board, the HIV, direct HIV impact and AIDS-related deaths and all of the deaths are significantly reduced, but we also have the social and the economic impacts. Let's move to the next slide because we are now moving into the proposals. I'm going to try to do this fast so that I don't take too much time. We are looking in 2 directions, and I already mentioned those in my introduction. We are looking at the resource needs and where do we get the resources from, and we are looking at the better use and the efficiency gains. Resource needs, well, the first thing we are here putting points for our advocacy, our joint advocacy. I would say we need to earmark and find ways of protecting healthcare allocations within government budgets. And I would say specifically from in a time of restrictions and in a time of debt pressures. I don't have the latest numbers for South Africa, but I have the latest from some other important countries in the region. Kenya has increased the debt repayments, and it's now up to 9 times more than health spending, which is a terrible evolution. And we see that there is these 2 are communicating. So we need action in that front. So earmarking healthcare allocations is very important. Second, implementing measures to address tax evasion and to ensure that we can move towards, in some places, tax reform, in some other places, to expand tax collection. I mean, South Africa is a very solid economy and has a strong tax system, unlike some other countries in the region. But this is definitely a challenge for the overall to sustain the overall AIDS response and increase health financing. We're also wanting to enhance the financial support offered by international financial institutions. Here we look at that third bucket, development banks, DFIs, development finance institutions, their blended instruments, these new opportunities. We need to tap into this because the constraints are significant. And I have to say, I think that health and HIV investments are being left behind in all these new instruments under design. So we are seeing that the focus on resilience, which is fundamental. The focus on climate change issues and the focus on economic recovery are prevailing. And I think we need to make sure that we make a strong case for health for economic recovery, health for health security, and for better preparedness, and that HIV is nuclear to this, to the expansion of these, of the use of these instruments for the ends of ending AIDS. Then we have more concretely pro-health taxes to generate revenue for healthcare spending. And finally, fostering alignment and coordination between key stakeholders so that we can bolster the sustainability through multi-sector co-financing, how to align the big international actors, the other multilaterals, the bilaterals, and private sector together to get to make the best of it. And next slide, please. In this way forward, there is a second pathway that is maximizing the effective utility of resources and partnerships. And first, we are looking at some of the proposals coming through are moving towards integrated health service models, securing equitable access for the most vulnerable, looking for cost-effective approaches to enhancing the accessibility and uptake of services. And there, I think the AIDS response has a lot to contribute to health integrated services and has a lot to gain also if this is done rightly and no one is left behind. So the key populations, vulnerable populations, are fully integrated. That is a challenge. That is not, we cannot take it as granted. The second one is on that same line, integrating HIV services into national health financing, including the different instruments, including health insurance instruments that are around. We are seeing some concerning signals, some places where HIV is left aside or not included, or the situation is not far from ideal. But that integration should be a boost to maximize efficiency and the best use of resources and partnerships. Third is engaging in public-private partnerships to support and strengthen health systems and health infrastructure that is so important and such a great contribution of the AIDS response to gain some of these other dividends. And finally, sustaining community-led response to HIV as a means of enhancing equitable access to care. It's clear that to deliver last mile services in prevention, testing and treatment, and I would say prevention and testing, we are lagging behind now. So this is a matter of a real concern. This is one of the big responses that we need to take into account. So this is the menu for action into the future. Let me move to the next slide and just share some final numbers with you all. Next slide, please. Yes, these are just some numbers recapping on for South Africa so that you have them fresh for the time that we engage in conversation. First, the total HIV cases averted in this in the results in the two different scenarios. It's 1,353,100 cases averted. I mentioned the exact number because every life does count. These are HIV incident reduction, and then AIDS-related deaths averted 661,400. And next slide, please. We have the all-cause mortality. I like to highlight, to underline this, is 958,000 fewer deaths. You know well that pathway also between AIDS-related deaths and all-cause mortality, that would also be highly reduced. Change in birth, we will have 12,600 additional births and a difference in population size of 863,700. So these are all very important demographic impacts. And let's move finally to the social impact. Difference in school enrollment. You can see there an additional 130,600 children in school, and the difference in the number of orphan children. This is a massive impact, over 1,039,250 children that would not be orphan children with all that comes with. So finally, I think we are moving to the labor and the economic impacts. Next slide, please. Here we have the difference in employment relative to baseline with a plus 244%, 455 1,100 people, comparing both scenarios and knowing all the nuances that would need to be introduced when we talk about labor, of course, specifically in South Africa. And finally, GDP, gross domestic product, with an increase of 17 billion plus 2.78%. And while I'm an economist, and this is a very large number and a very relevant number that will make a huge difference to the economy and the lives of people in South Africa, I tend to be more connected with all the other results, but this is a critically relevant one, because we need to make a case. We need to make a case for the economic gains, and this is a very compelling one. And I'm going to leave it here saying, again, this is one exercise. There have been others. We are trying to bring an innovative approach with some nuances that can be made and based on or inspired by previous exercises that we have learned from and that we are connecting with and collaborating with. And I hope that out of this conversation today we can get new ideas for some joint work, or I guess for South Africa level work that can be done by the fantastic expert and excellent universities and institutions that are leading this field in South Africa. So thank you very much, colleagues, and over.
Thank you so much, Jaime, for that summary of what is a very comprehensive report, and particularly for those numbers on South Africa. And next up, we have Professor Gesine Meyer-Roth, who's going to give us an overview of what we know about costs and economic impact of HIV in South Africa. Gesine is a research associate professor at Boston University and at HERO here in South Africa. Gesine is a medical doctor and holds 2 doctoral degrees in physiology and in health economics. The research focuses on modeling methods for economic evaluation and translating research into recommendations for public policy, including for HIV, TB, COVID here in South Africa and in other Southern African countries. Thanks very much, Gesine. Over to you.
Thank you so much, Lisa. Thank you very much for the organizers for letting me give a little bit of an insight on what we know about the cost and economic impact of HIV in South Africa. So in contrast to the triple dividend report that we've heard about from Jaime just now, my presentation will focus on the retrospective perspective, where we're looking at what has been analyzed about the past impact, both in terms of the economic impact and the cost. Next slide, please. I present in these slides the work of a great number of colleagues, and I want to highlight especially Nhlanhla and Lungisi Duma from SIGA, who've contributed to the expenditure analysis that I will present in a minute, as well as Marcus Hacker, who's done a lot of the work on summarizing the macroeconomic impacts of HIV. Next slide. So firstly, what do we know about the impact of HIV on economic growth in particular? That is the magical 2.87% that Jaime just presented as having been projected as a difference on GDP per capita, that between doing business as usual and fully funding the HIV response in South Africa for the future. However, what do we know about the past? Next slide. So I will dwell on the summary slide for a minute and then give you a lot more detail in terms of actual numbers for South Africa and other countries in the region. But for those of us who kind of, like me, tend to blaze over as soon as there are too many graphs and figures, this is really the take-home message. And that is that about 20 years ago, it was expected that up to half of young people growing up in countries with high HIV prevalence would eventually die because of AIDS. And because of the global effort to then fight HIV, such catastrophic impacts did not materialize anywhere. Now, that means for us as analysts that we will most likely never know just how bad HIV would have hit the economies around the globe, especially in high-income countries. And that by itself is one of the returns to this investment in the global response to HIV. So in other words, it is frustrating. We will never know just how bad it could have been, even though, to be quite frank, going into the future, if we don't keep up those funding levels, we will all live to find out how bad it could be in the future. Next slide. So going through some of those impacts, as we all know, AIDS-related mortality is highest among working age adults, and that reduces GDP growth, but it has an ambiguous effect on GDP per capita, depending on how that growth in the economy relates to the growth in the population. And we can see that on the right-hand side, where Botswana, for example, the difference in those blue lines between the HIV scenario, the solid line and the dotted line, no HIV was significant, whereas in Tanzania, a country with much lower HIV prevalence in the red lines, that difference was really quite marginal. Next. In terms of the impact on child mortality and birth rates, again, the picture is ambiguous in that reduced fertility and increased child mortality, both represented at the bottom in figures from South Africa, contributed by my colleague Lee Johnson. They raise GDP per capita in the short run, but result in lower growth of the working age population once those children that have not been born or that did die would have aged into the working age, and a reduction in the GDP in the longer run. And in South Africa, that would have been a significant difference, given that difference in mortality on the right-hand side between in blue of all causes, and including HIV, and the red one if HIV had not been there. Next. In terms of the overall effect of treatment then and the HIV response on life expectancy, we can see that increased early mortality resulted in a loss of experience, but that the HIV response itself affected human capital directly by reducing mortality, but also indirectly by increasing the incentives to invest again in skills and education. And that is represented here by the 3 countries with high HIV prevalence: Eswatini, Kenya, and Zambia on the left, and on the right, additionally, Sub-Saharan Africa overall, where we see these huge dips in, on the left, average age, but also in the middle, the returns to education proper over the years, where HIV was worst in between round about the turn of the millennium. Next. So as we know, the HIV response came to our rescue and meant that we never saw to see or live to see those huge impacts. Here is a quick representation of the HIV response's effect on life expectancy. And of course, the biggest effect there was because of the early impact of treatment, as well as PMTCT, in fact. So as you can see on the right-hand side, across regions, but especially in countries with high HIV prevalence, so especially over 10%, so that's the third bar there, the impact of the HIV response on increased life expectancy was really quite dramatic, and far outdid whatever we did to reduce the deaths from TB, malaria, and child mortality. Next. And this is not only true for life expectancy, we also know, and this is based on work from colleagues of mine at Boston University and at HERO, both of them, that the HIV response in itself, so treatment in particular, again, had a direct and measurable effect on work productivity as well. On the left is data representative of the productivity of tea plantation workers in Kenya, and on the right-hand side, productivity of across the board of people accessing ART in a cohort in Johannesburg. So we know that treatment has been effective because we have had good enough data in restoring the productivity of individuals, and then also the employment and employment chances of people living with HIV. And next. So in summary, the conclusions regarding the impact of HIV on economic growth as one of the main metrics really that we're looking at when we look at economic impacts is that there is a consensus that HIV through creating smaller population sizes than otherwise would slow down GDP and GDP growth. But we know that there is an effect that really goes both ways when it comes to the impact of GDP on average GDP, so GDP per capita, because GDP is being reduced, but at the same time, the population is also being reduced. We expected wild swings in growth in countries with HIV prevalence. That was some of the empirical work in the early 2000s, but this has generally not happened. But we do, in in summary, have some consistent evidence that HIV has had an impact on productivity and employment that was reversed by the HIV response. And I'm just summarizing work that Marcus Hacker and I led on a number that's summarized in a number of policy briefs that are all available on this website that go into a lot more detail on a number of additional aspects on the economic impact of HIV. Next. So a lot of this, next slide, did not take COVID into account because, of course, that again is retrospective work that happened mostly before the advent of the next pandemic, COVID-19. What's important when you now also additionally consider the impact of COVID is that COVID appeared in a situation to the right of this slightly blurry graph, apologies for that, on the right-hand side there, which only goes until 2019 and already shows in the light pink bars in the middle a reduction, a flatlining, but ultimately a reduction of bilateral donor funding of the HIV response globally at that stage, and an increase, and that's the bright pink bars right at the top, the red pink ones, an increase of domestic funding of HIV. Now, every time we see these bars in South Africa, we know that the absolute majority of that domestic funding of the HIV response globally is in fact contributed by the South African fiscus. South Africa being a country that is both unusually burdened with HIV, but also is a high middle income country that can contribute and is in fact contributing as it should to a large part to funding its own HIV response. So we have had this bilateral ODA that was already offset by increased domestic contributions according to the ability of countries to contribute to funding their own HIV response. But of course, in a way, also making it more tenuous and more prone to then severe productivity shocks, such as COVID, actually having an effect on the space available, the financial space available for HIV. Next. So when we look at the fiscal consequences of COVID-19, and this is, again, analysis by Marcus Hacker, which is quite recent, so looking at data from the end of 2022, we see that across countries there has been a lot of lost revenue, which was a lot more marked in developing countries. We also see a huge cost of the mitigation of COVID, and that's across the columns there, through expenditure directly for the COVID response, both the health response and additional social measures, such as loans, etc. The expenditure, but also foregone revenue. And then on the right-hand side, we also see large increases in loans and other guarantees. So that was those impacts were the largest across advanced economies. But if you look at the second set of numbers there across emerging markets, you see that South Africa has had one of the largest fiscal costs of COVID-19 amongst those emerging market economies. Next. So lastly, what do we know about the cost? Not so much the economic impact, but the cost of HIV in South Africa. Next slide. South Africa is, again, unusual in that not only we fund a lot of our own response, we also keep fairly good track of where that money goes and what it buys. This is the result of a recent National AIDS Spending Assessment, NASA, in fact, a NASA Plus that also included TV expenditure that colleagues of mine, led by Teresa Guthrie, did for 3 financial years, the last being 2019-20. So those 3 years are all over before COVID came around. So that basically takes us until March 2020. Here we can see that the money spent on HIV and TB in South Africa, now this is from all sources, so from all sources, increased quite dramatically over those 3 years to around about 38 billion rand in 2019-20. And the line share, as mentioned before, was borne by the government of South Africa. So that's the red in both the pie chart and the bar charts. As mentioned before, the government of South Africa funds just about or just a bit more than 2/3 of that very, that response, and that's about 69%. PEPFAR is the next largest funder with 24%. This is in 2019-20. And then there's a number of other bilateral funding agencies, of which, and the Global Fund is only contributes 2%. And medical insurances that have a number of people in the private sector on treatment, as well as HIV testing and a little bit of PrEP, only contribute about 3% to that pie. Next. I have two of these slides. They're a little bit hard to read, but I'll take you through them. So this one looks at, also from the NASA, at the flow of funding between financing entities on the left through to revenues in the middle, and then financing schemes. And the only thing that's really relevant here is that huge bar at the top, which basically says that government pays for about 2/3 of the money, raises this money themselves, and then puts it into basically government schemes. So in other words, government pays government to provide government services for HIV. The next bar, that gray one, that's directly underneath, is the bilateral funding, so PEPFAR and global funds funding that goes then directly to NGOs in almost all instances. On the right-hand side, that teal blue kind of bar. Next. When we look at the beneficiaries of those funding streams, again, at the top is government funding that goes into any number of program areas that mostly benefit, on the right-hand side, people living with HIV. If you look at the red bar underneath that, starting on the bottom, the financing through international entities, that goes in part to the same program areas that also, in a good part, benefit beneficiaries. Benefit people living with HIV as beneficiaries. But as you can see, and that's that slightly chaotic kind of split on the right-hand side underneath that orange bar, a lot of that goes into specific targeted populations, including key populations and other prevention and other activities. So in other words, most of the key population and prevention programming in South Africa is still funded, not by government, but by other entities. Next. Now, if we look at expenditure on HIV just by the government being the largest funder, but also over a longer period of time than those 3 years that were included in the NASA, we see the following picture. The health sector expenditure on HIV. So this is just the contribution borne by the National Department of Health, which is the biggest contributor to those 69% of the HIV and TB response that are borne by the government. So just the health sector's HIV response has increased almost threefold over the last 10 years. So on the left-hand side of this bar on the right, we see it starts in 2013, and the peak there, just before it drops again, is 2021. And that was the peak of around about 30 billion rand. That's a little less than what you saw in 2019-20 on the slide before, if you've been paying attention. Absolutely no problem if you haven't. But that other number that was slightly higher, 35 billion, included a lot more than just the health expenditure, and also included TB. So that is a good part of that kind of 5 billion that's missing here. After 2020-21, the percentage of total health expenditure that was spent on HIV increased slightly, dropped in fact from a height of 13% to now about 11%, and that's what we have in the current medium-term budget. And I would expect that my colleague Mark Betcher from the Treasury will expand on this a bit more. But basically, we've had this peak in 2021, which is in part explained by the fact that a number of the COVID response activities were also funded through the HIV Conditional Fund. Next. When we look at health as a share of government expenditure, so not only HIV, but the entire health budget, we see that the health budget took up about 12% of the government expenditure for many years, but this has then declined between 2018-19, 2019-20. So ahead of the COVID response, and now only we are at around about 10% of the total budget. Now the total budget has declined, but more importantly, also the health share of it has declined in the aftermath of COVID due to the increased financial constraints and the reduced fiscal space that COVID has left in its wake, which Jaime mentioned earlier. Next. So we have less money for the foreseeable future. What are we doing with it? How efficiently are we spending it? In South Africa, we do an annual exercise in allocative efficiency, which means we're trying to find out if there are ways of spending our HIV budget even more wisely and more efficiently, and essentially averting more deaths and more HIV infections. It's called the HIV investment case, and we do it annually. And this is the result of one of the first ones we did in 2016 and the one of the more recent ones in 2021. The order of interventions has not changed much between the original one in 2016. As always, condom provision is the most cost-effective intervention, followed by medical male circumcision and increasing ART coverage. That is still the case, with the only exception that now we find that the circumcision program is starting to saturate, and adding more circumcisions becomes a little less cost effective. That's an orange bar there that's dropped down over time. What is becoming more cost effective is PrEP and other prevention interventions that are not surgical. And that is true for both oral PrEP as well as injectable PrEP. We did this analysis with injectable cabotegravir as well. What's most important, though, is that now ART, and especially increasing linkage, but then also retention in ART, is one of the most cost-effective interventions, and really the last bit where we can add more bang for our buck. Next. In terms of the projected cost, we are at baseline, and that's the right graph here. We're expecting, if we do nothing else about our fairly middling ART retention and our attainment of the second 95 target of round about 78% ART coverage of people living with HIV, if we do nothing to increase that, we will be spending between 20 and 22 billion rand just on HIV over the foreseeable future. However, if we actually increased retention, ART retention, to the tune of meeting our second 95 target, we've already met the first and the third. It's really the middle one that's lagging behind, as well as adding prevention in the shape of cabotegravir or oral PrEP. We would be looking at a cost of around about 30 to 32 billion rand. And that is, as mentioned by Jaime, that's the 20% increase that we are expecting there, mostly out of more need for ART as well as those additional prevention interventions. Next. So in conclusion, the cost of HIV in South Africa has been round about 20 to 25 billion, or on easy 20 or 25 billion rand every year, on easy $2 to $3 billion for those joining us from outside South Africa. About 70% of that is borne by domestic resources and will most likely continue to do so in a situation where bilateral donor support will flatline. After a peak around the time of when COVID came around, the government spending on health and HIV has decreased, both in total terms and as a percentage of the government expenditure. But unfortunately, the same is true for bilateral funding, which has additional potential implications for the funding of NGOs and through them key population programs. Some of this decrease in both bilateral but also domestic resources is due to a decrease in the initiations of on ART during COVID-19. So not only do we have less money, we also needed a little less money than planned. So that is really important to bear in mind. And from our regular allocative efficiency modeling, we know that the only intervention that is left to optimize in South Africa is ART retention and novel prevention interventions, but only if we manage to get the uptake of, for example, injectable cabotegravir to far outperform the uptake or demand for oral PrEP. Thank you very much.
Many thanks, Gesine, for that sobering presentation. I would just like to invite everyone to post messages and comments or questions in the chat. We hope to have some time for live Q&A after our final presentation, which is from Dr. Mark Bletcher, who will reflect on the financing of HIV in South Africa. Mark is the Chief Director of the Health and Social Development in South Africa's National Treasury. He has a specialist degree in public health and a PhD in health economics and has published widely in both fields. His expertise in public sector health financing, planning and management has been built through employment at provincial and national government levels. And he has a special interest in the economics of health service delivery and programming. Over to you, Mark. Thank you.
Okay, thanks. Good afternoon, colleagues. I'm going to speak a little bit more broadly on health financing and HIV financing, looking more broadly than just South Africa, although I can perhaps end a bit on South Africa, also take some of the more discussion on South Africa in question time. All right, if we can, the slides should be up. If we can go to the first slide, the next slide, please. So welcome the paper, and I think the paper comes at a time where it rightfully points out that there's been a shift in attention to some extent in the global health financing and more broadly financing space to COVID, to inflation, Ukraine war type issues. During COVID, there's been a huge accumulation of backlogs in services and also in HIV services. In South Africa, for example, we would normally see a net increase in persons on antiretrovirals by about 400,000 a year. In the last 3 years, that's declined to about 150,000 net increase per year. So that reflects a big reduction, which is probably both a reduction in initiation, but also a decline in follow-up in existing people who are defaulting from treatment. So big backlogs emerging after COVID. At the same time as one sees major challenges in financing in many countries, the World Bank releasing the so-called double shocks, double recovery report with about 60 countries going into fairly severe financial stress after what was the biggest global recession in a century after COVID, with a lot of economies, particularly the South African economy amongst them, being shut down for many months. And then the accumulation of debt and interest payment problems in quite a number of countries. So one sees, for example, debt crises in Zambia, in Ghana, I think in Senegal, quite a lot of countries running into quite significant debt problems. And so, looking at this in a sense, the post-COVID environment, a lot of health budgets under pressure in quite a lot of sub-Saharan African countries, the issues of health financing being quite important. But I also want to talk a bit about benefit packages, given the increasing interest in many countries around health insurance, issues around donor substitution, of course, the big issue being domestic financing and sustainability, but also in the context of primary healthcare financing. So next slide, please. So I just want to talk a little bit about how HIV financing evolved, particularly in sub-Saharan African countries, particularly in the low-income countries which had very little fiscal capacity in the early days, and there was high mortality and low fiscal space, and so huge investments by donors, substantial dependence on donor financing which emerged, and a lot of literature showing then the emergence of donor substitution, so that as donors increased funding, countries would, in a sense, put their own financing into other resource areas. So one sees in many countries, the majority of sub-Saharan countries, the majority of financing being donor driven. Then going through a period where the costs of AIDS medicines reduced massively, And the situation has, in a sense, become so bad in many countries that with the emergence of health insurance packages in a lot of countries, or a number of countries, not a lot, a number of countries have actually excluded HIV from their benefit packages, which is completely the wrong financing incentive that one would have intended. It really suggests a major problem in the design of financing incentives. And in an environment where one clearly wants to see a sustainable transition path in many countries over years, particularly as those countries go through periods of economic growth, one needs to see linked to that a restructuring of donor incentives. Firstly, every country must have HIV in their benefit package, and one's got to look at that share of that composition of financing from the different sources changing over time, and one needs to plan it going forward over time. Also, I do want to point out the shift in thinking around HIV financing, perhaps over the last 10 to 20 years, where, when HIV first emerged as a crisis, there was this huge focus on HIV specifically. And whereas there's still a relevance in that, this was over a decade of a lot of emphasis on the UHC movement and UHC financing, and more recently over the past 5 years around primary healthcare financing. And it's important to locate HIV financing in countries within those two streams. Okay, next slide, please. So on HIV financing specifically, so on primary healthcare financing, somewhat more broadly, the Lancet Commission report last year was quite an important report, I think, on financing, particularly looking at low-income countries where there's very low domestic financing for primary healthcare in many low-income countries. And I'll try and show one or two slides on this from the Lancet report, which show really in low-income countries a huge reliance on out-of-pocket payments, which are actually the worst way of financing healthcare, and on donor funding. And so, given these huge gaps, one needs fairly decisive policies around a range of health financing areas. They include issues of national revenue raising and taxation, what kind of tax to GDP ratios countries are trying to move towards, how they pool funds, their policies around public financing for health, what is the share of health in general government revenue and general government expenditure, and building institutions. There are a whole range of institutions. And one needs to look at this HIV financing within the context of these PHC financing issues, and countries need to develop and look at their primary healthcare financing plans. And these are, of course, also within the wider context of UHC financing reform. Next slide, please. So this table came from the Lancet Commission report, and it showed this very, very surprising number of, in low-income countries, of $3 domestic spending for primary healthcare in low-income countries, and also actually a very low $16 in lower middle-income countries of domestic government-owned financing towards primary healthcare. Okay, next slide. And then if you look at how primary healthcare then is financed in low-income countries, what you see is this really strange mixture, and really wrong mixture, actually, of government across about, the Commission looked at about 100 countries, and across the spectrum of countries that it collected data for, $3 government spending on primary healthcare, $8 from donors, and we know that donor funding is particularly coming into areas like HIV and child vaccines, and then this predominance of out-of-pocket expenditure, where in many cases poor people are having to, trade off other kinds of living needs to be able to get healthcare and primary healthcare. So inadequate pooling, inadequate revenue raising and pooling mechanisms in the national financing systems in many low income and lower middle income countries. Okay, next slide. So this slide and the next, and I'm coming towards the end now, are from the last World Health Organization. Every year, WHO brings out in December their latest spending numbers, which all countries, almost all countries, about 192 countries report every year. And you know what this slide shows again is if you look at the composition, and generally health spending increased during the COVID period. But again, if you look in low-income countries, and there are quite a lot of this slide focuses mainly on African countries, one can see that government, which is in the blue here, in many countries is the minority funder for health. And this is a very substantial problem that we still have this dependency again on these other two major financing sources. So this is from the very latest, which is the 22 report from WHO, which is looking at data for the 2020 period, which is in the heart of the COVID period. Okay, next slide. And this shows, this again is WHO data from that 22 report, showing the proportion of government spending going to health. And one can see this 7%. And one sees this problem of the 6 to 7% of the budget going to health in many low-income countries. One looks even 8% in low middle income countries. Of being very low. So this continual problem of prioritization of health in government budgets. Okay, next slide, and I think this is the last one. Okay, so we need to have country health financing plans. They need to, besides HIV, also look at primary healthcare financing and UHC financing more broadly. The issues about the structuring of the budget process within countries, the relationships and the process of that budget process, how it works in every country between departments, their Ministry of Finance and their Parliament, and how the budget process works week by week and month by month. One needs to look at institutional building in quite a number of the countries, both in terms of the health financing institutions, but also the tax-raising institutions and others. HIV/AIDS must be part of benefit packages. Where countries don't have HIV/AIDS as part of their benefit packages, there should really be serious, severe penalties from the global donor community. We need to restructure donor incentives because many countries are substituting substantially. And we need to look at long-term sustainability plans. Because I think I've spoken a bit over time and it's already 3:18, I think I'm not going to go on to a lot of the government, the South Africa specific issues here, but let me just make one point, is that I think, one small point, is that I think that there are some errors in the last 2 or 3 slides that Gesine has presented. South Africa's health share of health financing has not decreased from 15 to 10% as is presented there. That data is incorrect. So I'm not sure where that's been sourced from. If you look, for example, at the recent WHO publication, I mean, they cite 15% health spending share in South Africa. I think that's a bit high. I think we've been fairly constant at around 13 to 14%, but it depends a bit on which indicator one is using. What I should point out, though, is that South Africa, like quite a number of other countries, has been spending a lot more on debt servicing, and debt servicing has been squeezing out a lot of expenditure. But there are some errors in 1 or 2 of those slides, which I'm happy to talk to Gesine to correct those. But back to you, Chairperson.
Thank you very much, Mark, for that overview of health financing, which was indeed your brief. My apologies, that was my mistake. I will hand back to Jürgen for some Q&A before we close out with Anne. Thank you, Jürgen.
Great, thanks very much, Liesl, and thanks to the 4 presenters for a very entertaining set of presentations. Gesine, there are 2 questions that I'd like you to react to that came in the chat. The one is around from Temba about GDP. I hope you can see the chat. And the other is around condoms. We spend a lot of money on condoms, and your analysis shows that it's a good thing to spend on. but is it making a difference? So Gesine, can you respond briefly to those two, and then we'll ask Jaime to respond to the first question from Mona. Over to you, Gesine.
So Tema, thank you very much. So I think you're referring to exactly some of those studies that I mentioned in passing, the very early modeling, in particular in Botswana. I know similar studies for South Africa, and Mark and I actually had discussions over the years about them, where I think at some stage, and this is not analysis that I was involved in, it's way before my time, showed or didn't show, but estimated, right? And a potential 20%, I think, reduction in GDP in South Africa. Now, what I focused on is GDP per capita, which is really the size of the economy on average, right, per person. And it is really in that measure that the ambiguity lies. So GDP absolutely would only ever have reduced in a shrinking workforce, but in considerable mortality impact on the working age population, GDP would have reduced. Now the question is, if you're by the same token reducing your population, your denominator for the GDP per capita, what is the end effect on GDP per capita? And it might decrease, it might increase, but that is the metric that most people, or that seems to be driving a lot of policy. The average income, or the average prosperity, as it were, of a country, rather than the total size of the economy. And that is where evidence went, or not evidence, but again, estimates went both ways, really, in the end. So I don't know if that really answers your question, but basically, there was a number of those modeling exercises focusing on the impact on GDP that would have been large. And as I said, there's no way that we can ever estimate how much it has been, because it never came to be as bad as in those estimations. Also because those estimations then
the next question, please, Gesine, because of time constraints.
Yeah. For condoms, so we know from a retrospective analysis led by Lee Johnson, the developer of the Tembisa HIV transmission model that we use for all modeling and decision making and budgeting, in fact, in South Africa, that the provision of condoms is the single most effective intervention when it comes to HIV incidence in South Africa, followed by ART. I don't have the exact percentage of reduction in incidence at hand, but it is the most effective, or has been over the last 20 years. Thank you.
Great, thanks. We have time for just one more before we close. Jaime, could you respond to Peter Barron, who's basically suggesting that given the other pressures on the fiscus, is it possible, and with global fatigue for funding the HIV program, is there any likelihood that we can have the resources that we need to eliminate HIV by 2030 or even 2050? Over to you, Jaime. Jaime, you're on mute, unfortunately. Still on mute. Jaime, in the interest of time, could you type your response in the chat?
Sorry,
to that?
Can you hear me now?
Oh, yeah, now we can hear you. One minute, Jaime.
I unintendedly pressed the button. So the short answer is we are in danger. So we need to do a lot of work to make sure that we bring back the attention to HIV and health. And I think it can be done. It will require a massive effort by a number of agencies, international actors, and a strong work hand in hand with some partners here in the room, international donors, large foundations, other actors, and reaching out to governments and to other highly political voices and powerful allies. So that's the work we need to do. And I think there are very good arguments, and developing the narratives is the other side of what we need to do. So I have to say, the likelihood of getting the results, it's doubtful now because we are in danger, but the work ahead has also opportunities, and we have the right alliances, but we need to put them into action. So
Great.
there's a
Thanks,
danger.
Jaime.
Let's go for it.
Thanks very much, Jaime. And thanks very much to people who've asked questions on the chat. I'm sorry we didn't have more time to get into some of the nitty-gritties of can we afford it? Will we have the money? And indeed, will we be able to eliminate HIV by 2030? Or rather, control it is perhaps probably a better way of thinking about it. So in the last now 4 minutes, I'm going to hand over to Anne. As introduced previously, Anne is the Regional Director for UNAIDS. In Eastern and Southern Africa, and has more than 20 years of experience in a number of areas, including with UNDP. Over to you, Anne.
Thank you so much, Jürgen, and thank you for a really great webinar. I think we've all learned quite a bit in a very short space of time. So to you and Bill and Melinda Gates Foundation, thank you. Thank you, Eva and Liesel from Health Systems Trust for convening us. We really are excited about this. And to congratulate South Africa, really leading from in front. We are grateful for that. I'm jealously participating here, making sure that all our other 9 countries in this Eastern Southern African region will also be able to hold similar webinars. And of course, you know, learning from the conversation we've had, it's going to be very different from country to country, because this is a country where, you know, the bulk of the resources are coming from the state. In most of our other African countries in this region, up to 90% of the resources come from external partners. So that makes it a whole different conversation. And I hope you'll join us as we have these conversations in the region as well. So thank you, Jaime, for the presentation of the triple dividend report. It's really a great report, and I think you know, being able to leverage a partner like the Economic Impact has been very useful and really gives us a lot of insights into the work that we need to do. And so as I was listening to the different presentations, I thought I'll just highlight a couple of things that remain of concern that I think are important. Just then, it was so interesting to take us back to the 2000s when we were predicting that we would actually have a huge economic downturn impacted by HIV. It didn't happen in that way, but we're still concerned now that even though the impact is not like we had anticipated it with the advent of ARTs, we did a recent study on the cost of inaction, and that cost of inaction is pointing to the costs. These are hidden costs, the cost of transmission to adolescent girls and young women through GBV, through teenage pregnancy, you know, through school dropouts. You know, these are numbers that are massive and have implications for economic growth in our countries. And so these are areas that we're also taking a look at. A second area of interest, obviously, is how do we make sure that the balance of resources are invested as much in prevention as in the treatment agenda, because as we know from our global AIDS strategy, this is the work that's left behind. We know what to do with the treatment agenda. We have the tools that we need to, but on prevention, we know about the combination prevention, but some of the social, structural, difficult stuff, economic vulnerability, human rights violations, gender inequalities, these are tough and they're expensive, and we don't quite know where and how to invest effectively. So these are still areas that we need to look at as we think about the allocative and implementation efficiencies. And so let's keep pushing on this. And I want to thank Dr. Mark Blecher. Great to see you again after many years. Prof. Maya, thank you for your presentations, for your insights into this study. My dear sister, Dr. Kulu, thank you for always being present and available to energize us, and looking forward to seeing how this report will impact on the way that the new NSP is going to roll out. And I know you've been really, really strong in pushing to make sure that the prevention agenda is strongly supported. And so last but not least, you know, great to have seen all the attendance and great to see many people here. And I don't know, Jürgen, usually, you know, I don't know if the system allows us, we're great to see everybody's faces so that we can, you know, sort of wave and give a thumbs up, because I think this has been an excellent presentation, an excellent webinar. Thank you all for your participation. where we can see people's photos. Let's see it and say, give a nice wave, a goodbye, a thumbs up. Thanks, Liesel. Thank you all. Wonderful to see everyone. Really, really appreciate this. If we can, all those with pretty faces, you know, show face. I used to hear that economists don't like showing their faces, but you know, for those of us who are here, thank you. Really appreciate your participation.
Great. Thanks very much, everyone. So more mobilization required to mobilize more funding. So activism, activism, activism. Thanks very much, everyone. And thanks for the organization. Bye-bye.
Take care.
Thank you. Bye. Take care.
Thanks.